All right. So let's just kind of jump into the session for today. So first off, if you have not had a Q&A session with me, you haven't had a tutoring session or even a class with me, a little bit about myself. I am Tiffany Roach. I have been in the coding industry since 2007. I've been an instructor with AAPC since 2016. I have been with Legacy Education since 2022, so a little over a year and a half now. And then before that, previously, I did teach with some local colleges here in Louisville, Kentucky. So I've always been into education. So this has just kind of always been my passion. So. We're going to jump into the first question today. So our first question is, can you please review when you would and would not use a combo code for diabetes, chronic kidney disease, hypertension, and CHF? So we do have a guideline here for the chronic kidney disease, hypertension, and CHF from the chapter 9 of ICD-10. And and I think I misunderstood this question until honestly right now. I'm going to apologize because I have had COVID brain. I have been getting over COVID slowly over the holidays. So in my head, whenever I wrote this question and this answer out, I was thinking you were referring to the chronic kidney disease, hypertension, and CHF linkage. But whenever it comes to diabetes, so when it comes to diabetes, there is again another guideline within ICD-10. I'll have to get the section in the chapter for you guys for that. But in your alphabetic index, then unless the doctor specifically states that they are not related, then you are able to code them together. And that's because in your alphabetic index, there is an entry underneath diabetes and then kidney complications or circulatory complications or something along those lines. So you can always assume that you have diabetes complicated by the chronic kidney disease or hypertension or CHF. Like I said, unless you have documentation that specifically states from that provider that the conditions are unrelated, that the diabetes is not complicated by the chronic kidney disease or it's not complicated by the hypertension. Very rarely will you actually see the provider document that they are unrelated, but it does happen. Oh, sorry, my screen share just went away. Let me get it back up. Don't know where everything went, so give me just a second here. I don't know how that happened. So, sorry guys. Technology is not my friend today. All right, can you guys see the screen now? Let me know if you can see that in the chat. Perfect. Okay. I apologize about that. Technology, my computer's been acting kind of crazy today. So, again, just to kind of reiterate what I said, unless you have that documentation that clearly states that the conditions are unrelated, then we would always want to assume that the diabetes is complicated. Okay. All right. So the next question that we had today, and honestly, we only had 2 questions that were submitted for today. So I'm going to kind of expand on modifiers just in general. So the question is, they came across the topic about modifiers 26 and TC and wanted to request going over this topic and any other modifiers that you think that we would run into in the field. So I wanted to take the rest of the time today to just kind of touch on modifiers, the most common modifiers. I'm not going to go over every single modifier, but these are the most common modifiers that you guys will see. Again, this is not an all-inclusive list, so I do want to just kind of preface with that. So the first modifier that we'll go over today is going to be those 26 and TC modifiers, since that is what the question was about. So certain procedures are going to be a combination of a professional component and a technical component. So your global modifiers 26 and TC are going to be used for procedures that are containing a technical and a professional component. Modifier 26 is going to indicate the professional component, and then modifier TC will represent the technical component. The global procedure, however, is going to be reported with no modifier because it includes both the professional and technical component. So when we talk about professional components and technical components, before we get into the example, essentially what the difference is between those two. Your professional component is going to be when the provider actually reads the image or whatever the result is of, and they are typically used in radiology. So that's going to be where you're going to use or see them the most. So that's what I'm going to use as my example. They're going to read the image that is given. So they're going to look at an x-ray and say everything looks good, or they're going to look at it and say there's a break. They're going to look at a CT scan and say there's no abnormalities, or we see, whatever their professional opinion is, using their medical expertise to be able to say this is what are the results of the CT scan or the x-ray or the MRI. Okay. That technical component is going to be anything that for the facility or whoever owns the equipment to be able to give the service. So it's going to be the rent or the payment on the machine. It's going to be the electricity that helps run the machine. It's going to be the x-ray tech or the nurse or whoever it is that is actually giving the service. It's going to be basically any overhead for performing that service. Okay. So again, your professional component is going to be the professional opinion or the medical opinion of the provider. Your technical component is going to be the technical things that kind of surround the instance for giving that service. So an example is if we have a patient who comes into the office with wheezing and congestion, the physician takes a 2-view chest x-ray using his or her own equipment and then sends it out to be read by the radiologist. So the office is going to report the technical component for the 71046 for the use of the equipment and the radiologist or the technician that is giving the test. And then the radiologist is going to report the 71046 with a 26 modifier for their interpretation of the films and the professional service. So if the physician performs an x-ray in the office and they perform the interpretation within the office, then we would only report the 71046 without any modifiers to indicate that they did a global service. So they are performing both the technical and the professional components within the office, and they are not sending out the x-ray for that professional opinion outside of the office. Okay. The next one that we'll go over is going to be some global package modifiers. So our surgical global packages. So we have modifiers to append to codes in order to indicate that there's a special evaluation and management service during a global period. So your modifier 24, that is going to indicate an unrelated evaluation and management service that is performed by the same physician or other qualified healthcare professional during a post-operative period. So the example that we have here is in January, the patient was seen for an injury to the right index finger. So therefore they amputate the finger at the dip joint. Now, let's say in March, the patient is seen by the exact same physician, but they come in this time for a right leg infection. So because it is completely unrelated to that finger amputation surgery for that March visit, you are able to append your modifier 24 to the evaluation and management service so that we can get paid for that service for the leg infection. Okay. So in January, we are going to report that 26951 for the amputation of the finger. And then in March, we are going to report 99213 with a 24 modifier. Now, if we were to report the 99213 without that 24 modifier, then our insurance company is going to say, hey, there's a global surgery that was done that had a 90-day global period done in January. The same provider is doing an evaluation and management service, but there's not anything telling us that it was separate. So we're going to assume that that 99213 is related to that amputation. When we submit with that 24 modifier, then that will tell the insurance company that it was completely unrelated, and they will more than likely, I don't want to guarantee, but they will more than likely go ahead and issue payment for that 99213 for that service. Okay. Our modifier 25, this is going to indicate that the evaluation and management service was a significant and separately identifiable evaluation and management service by that same physician or other qualified healthcare professional. And the difference is this is going to be on the same day of a procedure or another service. So it's typically used when your documentation supports an evaluation and management service, as well as a minor procedure that's performed on the same day. Your minor procedure, that's going to be a procedure that has either a 0 or a 10-day global period. Okay. So the example for this is a patient visits the family doctor for chest pain. The provider performs a complete workup of the chest pain, and then they also remove a lesion on the patient's arm. So since the procedure of removing the lesion on the arm is significantly and separately identifiable from the office visit, then we are able to append the 25 modifier to our evaluation and management service, the 99213. And then our lesion that is the removal of the lesion, that's going to be coded with the 11400. 24 and 25 modifiers are only allowed to be reported on evaluation and management codes. So you should never report a 24 or a 25 on a surgery code or a radiology code or anything along those lines, or a medicine code. They should only be reported on evaluation and management codes. So there's just a little tidbit on that. Your 57, that is for your decision for surgery. So if you have an evaluation and management on the day before or the day of a major procedure, typically that is included in your major procedures global day 90 global day period. However, if you have an emergent situation where you have to have an evaluation and management or a service that is done in order to determine if a procedure needs to be done or what the course of treatment is going to be. If it is not a scheduled procedure, then you can potentially add a modifier 57 to your evaluation and management code. So an example is going to be if we have the patient visits an emergency department with acute right lower quadrant abdominal pain, and that increases with cough and motion. At that point, the provider determines that the patient has acute appendicitis, and they decide to immediately perform an appendectomy. So in this instance, because the decision for surgery was made during that visit, they wouldn't come to the ER and immediately know that they needed to have an appendectomy done, right? They would have to do a workup. They would have to do an exam. They're probably going to do scans. They're going to make sure what is wrong with the patient before we perform that appendectomy. So in that instance, we are able to append our modifier 57 to our evaluation and management code to be able to say, hey, we know that this appendectomy technically has a 90-day global period. However, this was not a scheduled procedure. It was not planned. The patient didn't decide, hey, on January 27th, I'm going to go in and have an appendectomy. I'm going to decide that my appendix is going to be completely inflamed and I want to, have this major procedure done. So they are going to be able to say that we had to be able to do some type of a workup. We had to be able to determine what was wrong with that patient in order to perform the correct procedure. So we would like to be paid for that procedure. Okay. So that is going to technically unbundle it from that global period and be able to say that we had to medically, this exam was medically necessary in order to perform the procedure. The next one is for a modifier 58. That is going to be used to indicate that there's a planned procedure performed during a post-op period, or it's a related service that's performed during the post-op period that is more extensive than the original procedure. Okay. It can also be used to indicate that therapy is performed following a surgical procedure. So the best example and the easiest to understand example here is you have a patient that has a breast biopsy done on March 2nd. They send those results off to the lab. And at that point, the lab comes back and says that there is a malignancy. So we have to go in and do a mastectomy. So the patient is then diagnosed with the breast cancer, and then that same physician decides to perform that modified radical mastectomy on the right breast on the March 6th. Now, since that is within the, I believe the breast biopsy is a 10-day global period. But since that is within your global period of your breast biopsy, then you would append the modifier 58 to the modified radical mastectomy, not to the biopsy, but to the modified radical mastectomy in order to indicate that we had to do the breast biopsy to be able to determine what the behavior is of that lesion that we biopsied. And then we were able to get the results for that lesion of the biopsy. They are diagnosed with cancer. We don't want to wait until the global period is over, because obviously if it's cancer, we need to remove it as quickly as possible. So we went in and did the mastectomy. Okay. So that is, again, quote unquote, unbundling that mastectomy from the biopsy. And that modifier 58 is going to essentially reset the global day period. Okay. So that your modified radical mastectomy is going to have a 90-day global period that will start on March 6th if you append your modifier 58. Now, if you did not append your modifier 58, again, they are going to assume that that modified radical mastectomy is included within the procedure for, or the global day package for that breast biopsy. So it's very important that you are appending those modifiers to reset your global packages. Next, we have a modifier. I'm so sorry. A modifier 78. And that is going to be used when there's an unplanned return to the operating room. So if we have a patient that has a gastric bypass that was done in January, which has a 90-day global period, and then in March, the patient is diagnosed with an incisional hernia at the location of the bypass incision. So the patient is then taken to the operating room in March for a repair of that incisional hernia. Now, since that gastric bypass and the incisional hernia is done within that 90-day global period of the gastric bypass, we would need to append a modifier 78 to our hernia repair code in order to say that it is technically a complication, but it is an unplanned return to the operating room that we were not expecting to have to do, but we're still, it's not part of that typical global package. So we should be paid in addition to that gastric bypass for the repair of the hernia on the incision. Next, we have a modifier 79. This is for an unrelated procedure or service by the same physician during the post-operative period. So for example, patient is seen for an injury to the right index finger in January. In March of the same year, they had a below the knee amputation. So that is going to be completely unrelated to the amputation of the dip joint. So they are going to append the modifier 79 to the amputation to be able to say, yes, we know that we did the amputation in January. We know that it has a 90-day global period. I know I'm the same provider. I'm going in to do another surgical procedure, but I need to show that this is unrelated and it had no, or the amputation to the dip joint of the finger had no impact and is not the reason that we're having to do the below the knee amputation. So you would append your modifier 79 to your BKA that's unrelated to your finger amputation. Modifier 22, this is going to be for increased procedural services. So this is going to be used when the usual work to perform a procedure is significantly greater than what is typically required. When you use this modifier, it is required that you submit the operative report with the claim form, because just because you append a modifier 22, there's not just a, oh, we're going to pay them an extra 5%. They want to look at the report, make sure that there is support for the additional work, and then as well as the reason for the additional work. And basically what they're going to look for is they're going to look for increased time, any increased technical difficulty, if there's a severity of the patient's condition, basically anything saying that if we were to perform this procedure, technically and typically it should only take 25 minutes. But for whatever reason, the procedure took 45 minutes. Okay. So if that's the case, we want to make sure that it's documented if there were any complications, any extensive work that was done. Again, if the patient's condition, required that it took longer to perform the procedure. So your modifier 22 should be reported to the procedure code. Okay. If for some reason you do have an evaluation and management service on the same day, then it should only be reported on your procedure codes. Now, if you have an evaluation and management service that exceeds the time frame, you would not ever report a modifier 22. At that point, you would report the prolonged services codes for your evaluation and management. Okay. So just remember your modifier 22 is only going to be reported on surgical services. So an example of this is if we have a patient who has had a colonoscopy or is having a colonoscopy and a polyp is removed. The removal of the polyp causes excessive bleeding and therefore an extra 30 minutes is spent controlling that bleeding. You would report your modifier 22 on the surgical code, and then you would submit an operative report into the insurance payer with the claim, which is going to support the need for appending that modifier 22. Modifier 50. Okay. This indicates when you have bilateral procedures. So your CPT definition for modifier 50 reads as follows. Unless otherwise identified in the listings, bilateral procedures that are performed at the same operative session should be identified by appending modifier 50 to the appropriate 5-digit code. Some of your payers are going to differ on how you should submit bilateral procedures. So it's important that you understand your insurance payer's policy for that requirement. Some payers are going to ask that you submit it as a one-line item with a modifier 50 appended to it. Others are going to request that you add or that you have 2 lines with modifier 50 on the second line. And then some insurance payers may ask you to use your modifier or your HCPCS code or your CPT code with modifier LT and or RT. Okay. So just make sure that you understand which insurance payer you are submitting it to. Most of them will recognize just a single line with a 50 modifier, but just in case you do have a payer that is going to be a little more specific in their requirements, it's important to know. Now, it's important that you pay close attention to your code descriptions, as some of your codes will include in the description unilateral or bilateral. So you do have some other codes that specify unilateral, and then you may have a parenthetical statement that says, in order to report a bilateral procedure, use your modifier 50. So we have some examples here for code 50592. This code description is going to be for an ablation of one or more renal tumors, percutaneous, unilateral radiofrequency. So in this instance, you would be able to report the 50 modifier if it was done bilaterally. But then you have another code example here, which is 58900. This is a biopsy of the ovary, unilateral or bilateral. So we are unable to use your modifier 50 on this code if a biopsy is performed on both of your ovaries. Modifier 51, this is going to be used when multiple procedures are performed during the same session by the same provider. So your primary procedure is going to be the one with the highest relative value unit, or RVU, and it's going to be reported first with your additional procedure or procedures if you have more than 2 procedures identified with a modifier 51. So let's say, for example, we have an orthopedic surgeon who performs a closed treatment of a femoral shaft fracture on the left leg. And then you have a closed treatment of a right knee dislocation during the same operative session. So this is going to be coded as 27500 LT. And then you have 27552 with a 51 as well as an RT modifier. So it's important to note that your modifier 51 is not able to be used on evaluation and management services, physical medicine, or rehabilitation services. And then the provision of supplies such as your vaccine or codes that are designated as add-on procedures. So basically what that means is it should only be reported on a surgery code, and anything that is an add-on code is automatically exempt from modifier 51, because we know that if we have an add-on code, it is going to be an additional procedure in addition to another procedure, right? So it would be redundant to add a modifier 51 onto an add-on code. So it's inappropriate to report that 51 modifier on an add-on code. Okay, so that's important to remember. Next, we have modifier 52, which is used to indicate our reduced services. So if a procedure is partially reduced or eliminated at the provider's discretion, then you want to append a modifier 52. If a bilateral service, so something that our CPT code specifically states is a bilateral service, is performed unilaterally, then you are able to report a 52 in order to indicate that it was not done bilaterally. Sometimes you will see a parenthetical instruction that explains additional circumstances when you should use a modifier 52. So if you look at CPT code 43770, there is a parenthetical instruction that states to report modifier 52 with 43770 if there is an individual component placed of that gastric restrictive device. Next, we have modifier 53, and this represents a discontinued procedure. So if a procedure is terminated due to extenuating circumstances or any circumstances that threaten the well-being of the patient, then we should use modifier 53 with your procedure code. You will see a note in the definition of this modifier back in Appendix A that tells us not to use modifier 53 to report the elective cancelization of a procedure prior to the induction of anesthesia or surgical prep within the OR suite. So an example that we have here is a patient is having a surgical procedure, and then after the administration of general anesthesia, they begin to exhibit unstable vital signs. At the recommendation of the anesthesiologist, then the surgeon decides to terminate the procedure. So how we would report this is we would put in the surgical procedure that was planned to be done and was begun. And then we would report a modifier 53 to indicate that the service was discontinued. Again, it should only be used if the well-being of the patient is threatened or if there are extenuating circumstances. Next, we have our assistant surgeon modifier. So we have 3 different modifiers that can indicate that an assistant surgeon was used. And the difference between them is modifier 80 is used when you have a physician assist another physician during a procedure. So if an assistant surgeon assists a primary surgeon and they are present for the entire operation or at least a substantial portion of it, then the assisting physician should report the same surgical procedure as the primary surgeon, and then they would report the modifier 80 for their service. Your modifier 81 is used for a minimum assistant surgeon. So there may be instances when a primary surgeon has to plan a surgery alone. However, during the operation, there are circumstances that arise that do require the services of an assistant surgeon, but it's only for a short amount of time. So in this case, again, your second surgeon is going to report the same surgical procedure as the primary surgeon, and then they will append a modifier 51. And then lastly, you have a modifier 82. Your modifier 82 is going to be used when a qualified resident surgeon is unavailable. So these are going to be used in your teaching hospitals with your surgical residents on staff, but there happens to be no resident available to assist. So at that point, they do call on another surgeon or a surgical like an attending, and then they will be used as your assistant surgeon. So at that point, again, we are going to use the same CPT modifier, and then we are going to append, or I'm sorry, the same CPT code for the surgery. And then we are going to append modifier 82 to the assistant surgeon claim. And then lastly, we have modifier 63. So modifier 63 is going to be used for procedures that are performed on infants that weigh less than 4 kilograms. So this is going to have an increased complexity of physician work associated with these patients. And it's going to be like your temperature control, obtaining your IV access, and just making sure that the patient is stable in general. So you want to make sure that you read the note that's part of the definition within Appendix A about the modifier 63 that indicates that some procedures do automatically include the work of a modifier 63 for infants that are less than 4 kilograms. So you have 2 instances when you would not use a modifier 63 on a procedure on someone that's less than 4 kilograms. Example number 1 is if you have in CPT code 31520, you have modifier 60, you have a parenthetical instruction that states not to report modifier 63 in conjunction with 31520. Okay. Also, you can have an instance where the CPT code description for a certain code could already indicate that the procedure is being done on an infant less than 4 kilograms. So if that's the case and you have the CPT description that indicates that the patient is an infant less than 4 kilograms, then appending that modifier 63 would be redundant. So it would be inappropriate. Now you do have a Appendix F in the CPT manual that does list it does have a list of all of the codes that are exempt from modifier 63. So if you are ever second guessing yourself as to whether or not the modifier 63 would be appropriate, then you can check your Appendix F to determine whether or not you can append that modifier 63. Okay. So I wanted to give a little bit of time for those that joined. If you have additional questions, or if there's questions on any of the modifiers that I went over, or on the very first question about the diabetes and hypertension, chronic kidney disease, and congestive heart failure. So are there any questions that anybody has that you want to kind of just quickly go over? You can either type it in the chat. You can come off of mute if you would like. Yes. So doctors should weigh in kilograms. Most of your doctor's offices and most of your documentation with the with the implementation of EMRs. I know all of my doctor's offices input. Oh man, hang on, this computer went crazy again. All of my doctor's offices always weigh in kilograms. And then in the chart, it gives not only kilograms, but then it translates it to pounds as well. So you should always have documentation in your chart in kilograms, not only for infants and babies, but for just in general. I know that that is the more accepted, oh my gosh, what's the word? It's the more accepted unit, I think is the word that I'm trying to think of. So you should always see weight in kilograms. You're welcome. Any other questions? Okay. So I'm going to put in the chat the CEU certificate for today. So let me get that here. So if you are currently certified, then you are able to earn 1 CEU for today's session. If you attended the previous Q&A session that we had in December, then it is the same CEU number. So unfortunately, at this point, we have only gotten 1 CEU number for the Q&A sessions. We are in the process of getting additional CEU numbers for future sessions. However, I just wanted to kind of give the heads up that if you have the CEU number from the previous session, then it's going to be the same. So unfortunately, you're not going to get a CEU from last time and a CEU for this time. That is hopefully going to change for future sessions, but just a little disclaimer on that. Our next session is going to be on February the 10th. It is another Saturday, and again at 1 p.m. Eastern Standard Time. And then for the next session, I will get a Facebook group created again. But for the next session, we would use the same Google Forms for submission of questions for the next session. The link is here. Again, it's going to be posted in the event on Facebook, just because it's not like a super easy, common one to type in. But it will be included in the next session. But if you have a question that you think of prior to that Facebook event being created, then please feel free to go to the event for today and use the form or the link for the form, and it's just kind of a running list that I have. Just as a reminder of any of the questions that are submitted, the ones that we're more than likely going to choose for future Q&A sessions are going to be ones that are directly related to coding. So I know that we've had some questions about, do we think that AI is going to take over the need for coders and things like that? We are not going to choose questions like that just because We have specific requirements in order to meet um, the for CEUs, and opinions and things like that as far as AI moving forward. Those unfortunately don't meet the requirements for CEUs. So just if you do submit a question, try to keep it directly related to coding, and those will more than likely, be the ones that we cover. Michelle, we are going to, I'm not 100% sure where we are going to place the Q&A sessions. I believe Rachel and I have talked about getting them into YouTube. I don't know if we have it set up yet or not. Rachel was in the process of working on it, of getting YouTube and everything set up and being able to house as much as we can. But I'm not 100% sure, so I can't really give you a 100% certain answer at this point. But as soon as we get it up and uploaded to wherever it's going to be housed, I will put it in as a link into the Facebook event so that you guys can go back and look at it at a future I'm sorry, at a future date. Okay. Any other questions that you guys can think of before we hop off for today? I know we have like an extra like 15 minutes. So if you guys have any, like just random things you might want to think about, then just let me know. Okay. Well, if you guys think of anything between now and the next session in February, please feel free to submit that to the form so that we can put that on our next session. And then if you have any questions whatsoever that may not be directly related to like a coding scenario, and you want to just kind of like chat about opinions or anything like that, please feel free to, shoot me a message on Facebook, and I'll be happy to answer anything that I can. So you all have a good rest of your Saturday afternoon, and I hope everyone stays warm in this cold snap. It seems like it's kind of hitting everybody. So again, have a great afternoon. Thank you.